Thank you, Chairman. Thank you, Organizing Committee. Thank you, Dr. Waham. And thank you who stayed and attended the lecture. Now it's a bit different. We conclude this meeting with something related to a disease which is really frustrating. In my life, I had two situations which I felt frustrated. Talking to a young lady having a breast cancer when she is in the 20s, and a young lady coming with premature ovarian failure to tell her that she is having a premature ovarian failure. Until I discovered that some of those cases, we are late in diagnosis and we could have helped them by many ways. Let's go through what's the premature ovarian failure. This is the content of my talk, and of course, I have nothing to disclose about this lecture. The ISHRI meeting, which is the European Society of Human Reproduction and Embryology, have defined the premature ovarian failure. And ISHRI, one of the well-known bodies in reproductive medicine. It is onset of menstrual disturbances, whether oligomenorrhea or amenorrhea, for at least 4 months, associated with high level of FSH, more than 25, and this should be measured twice within 4 weeks, and the patient should be before the age of 40. This is the definition till the year 2016. They haven't updated this definition till this moment. Going back to the history, Fuller Albright was the first one to describe the premature ovarian failure in patients who are having short stature. He described 10 cases of those patients, and eventually they were named Turner's syndrome. And he described it to differentiate it between the premature ovarian failure, which is primary ovarian insufficiency, secondary to failure of the pituitary producing FSH and other hormones. But in the history, the Chinese have in their literature something described what is similar to premature ovarian failure, and this is a book documenting that in their history. But the first case report was by Demore, Rohan and Jones in 1967, and they described a patient who had premature ovarian failure before the age of 40. And in 1950, Atria was the first to describe that in 20 young women before the age of 35, who having all the symptomatology of the premature ovarian failure. The incidence of premature ovarian failure, it's 1 in 10,000 in those who are younger than 20, 1 in 1,000 who are younger than 30, and 1 in 100 for those who are younger than 40. And I want to say that nowadays we are seeing more than 25% of our cases coming for assisted reproduction above the age of 40. Of course, the medical triad is amenorrhea, hypergonadotrophic hormones, and hypoestrogenism. There are stages in the life of the female, and these are 4 stages of the menopause. The first one is the premenopause, which is from the first day of menstruation, first day of the first menstruation, I mean the menarche, till supposedly to be the age of menopause. But sometimes in between we have what's called premenopause. And this is abnormality or fluctuation in the level of estrogen and decline in the production of these hormones, the FSH and LH, sometimes with symptoms of hot flushes and period irregularity. But some of those patients go into premature menopause between the age of 34 and 45. And the next one is the proper menopause, which comes around the 52 years of age. And with this, the full-blown picture of menopause, like the hot flushes, night sweats, and others. And usually, there should be cessation of the menstruation for complete 12 months. Then after that comes the post-menopause with all the sequelae of losing the estrogen and like the osteopenia and osteoporosis and heart disease. So when patients come to us, the initial investigations of those patients, we usually check their FSH and we check their estradiol and as well thyroid function and prolactin. But we forget most of the time to do autoimmune screen. We hardly check for the thyroid antibodies, for example, adrenal antibodies or anti-ovarian antibodies. We hardly check the karyotyping for those patients, forgetting that there are diseases like Fragile X and Turner syndrome are included in this group. Ultrasound scan to see the antral follicle count, and of course DEXA to assess the bone density, bone mineral density. And the true marker for those patients nowadays is what's called anti-Mullerian hormone. And this one is the predictive one which helps us to tell if those patients are going to have fertility treatment later on. Again, inhibin B is also important for those cases. Premature ovarian failure, the majority of those patients are having idiopathic reason for the premature ovarian failure. But the autoimmune disorders that are associated with this is autoimmune arthritis, Hashimoto thyroiditis, and I assure you that all of us have seen cases of Hashimoto thyroiditis, especially in the young ladies. Addison disease, type 1 diabetes mellitus, and pernicious anemia in the autoimmune group. In the genetic group, we have Turner syndrome, which is very common, and Fragile X syndrome. I have seen at least 3-4 cases of Fragile X syndrome, and the metabolic defects and enzymatic defect. In one study, it has shown that a strong correlation between the incidence of premature ovarian failure and certain variants in the inhibin alpha gene. But again, it's not only that. Chemotherapy, for those who are going to have chemotherapy, especially the young girls who are in their early 20s, will eventually end up having premature ovarian failure. And to tell you how bad it is, 3 days after starting chemotherapy, 87% of the primordial follicles, the credit in the ovary of the female, will be lost. And this is a big loss, a huge loss, 87%. Not only that, sometimes we do hysterectomy for one reason or another. The hysterectomy will increase the risk of premature ovarian failure double-fold. And again, in some cases where we do laparoscopic ovarian cystectomy and remove, for example, endometrioma, this will lead to diminishing of the ovarian reserve. And this will affect definitely the patients and sometimes can lead to premature ovarian failure. I have seen one patient who was 23 years of age who had laparoscopic ovarian drilling. And when she brought to me the DVD, the one who did laparoscopic ovarian drilling, he was burning the ovary, and the patient came with FSH 55. So he completely made her menopausal by his surgery. Environmental toxins as well can lead to premature ovarian failure. And the last one is the viral infections, mumps. Mumps is one of the diseases that can lead to infertility, especially in male, because of the limitation of the scrotum. But when usually there is an inflammatory process due to mumps, it can lead to sterility in male. We thought before that mumps in the female, because the ovaries are inside a huge space, they can expand, and eventually they will regress and go to their normal size, and that will not affect the ovaries. Unfortunately, it's not the case, and mumps can lead to premature ovarian failure later on, as well as the HIV viral infection. Again, we should keep in mind the Turner syndrome and the Fragile X syndrome as a cause, the toxins, as I said, and the autoimmune disease. And this autoimmune disease can lead to damage of the eggs, complete damage of the eggs, especially when those eggs are exposed to the viruses and other factors which are most often seen in the idiopathic group. The premature ovarian failure have been reviewed in Johns Hopkins University and classified. We have premature ovarian failure 1 related to gene FMR1, and the location of that gene is there on the screen. You can see in the first line. And they have named at least 6-7 types, different types of genes, and those genes eventually will lead to premature ovarian failure. So genetic study is recommended. We do for them what's called whole exome sequencing to look for the location of those genes and find out if they are at risk of having premature ovarian failure. Again, this is the prevalence of the disease, and the occurrence worldwide, it is 3.7%. In the United States, it's 1% in the white population, and it's 1.4% in the black population. In the Far East, the Chinese are having 0.5%, the occurrence, and the Japanese are having even less, 0.1%. So it varies from one place to another. Everybody knows the symptomatology, starting with hot flushes, night sweats, vaginal dryness, as well as the difficulty, insomnia, and other memory problems. Diagnosis again, age, amenorrhea, and elevated FSH and LH. And this is the diagnostic tests we do for the patients. We do pregnancy tests, we do FSH, we do ovarian reserve AMH, karyotyping, thyroid stimulating hormone, and the antibodies as well, and ultrasound to find out the antral follicle count, and of course, we do not forget the DEXA. What risk factors they have, those patients? Age usually is one of the risk factors, especially in the family who are having premature ovarian failure, family history, and of course, ovarian surgery, as I have mentioned, when we do ovarian cystectomy sometimes, or surgeries related to the uterus and ovaries. Oh my God. McLaren and Penny have made in London a review in the London district and have checked on what symptoms they have more and related that to the age, like the hot flushes, vaginal dryness, and mood swings. And of course, most of these are variable according to the age. And also, they have found that the genetic is the least cause and the idiopathic is the most common cause. And they have made a data sheet for those who are having premature ovarian failure and collected all the information related to this premature ovarian failure. Okay, the mechanism, how this premature ovarian failure happened. There is follicular migration defect during embryogenesis and early decrease in the primordial follicles, which eventually become the follicles later on, increased follicular death, and altered maturation or recruitment of primordial follicle. This will eventually lead to less number of follicles producing estrogen and, of course, premature ovarian failure. Mechanism, again, in Turner's is genetically, there is ovarian degeneration of the primordial follicles, and this will lead to gonadal dysgenesis. And, of course, in some women, the FSH may bind to FSH receptor site, but it becomes inactive. Those patients can benefit if we give them some estrogen, like estradiol valerate or ethinyl estradiol, and we keep them having their menstrual cycle vital, and then we can stimulate them. I'll show you in other slides. Of course, we have to check on the anti-Mullerian hormone. It is very important. Again, in the genetic, there are some mutations, like the mutation in FOXL3, and it can affect certain group of patients and end up with premature ovarian failure. Those patients are having DNA repair deficiency. BRCA1 protein plays an important role. The germline of BRCA1 mutation is very important, and it can lead to premature ovarian failure cases. These mutations have been found to be associated with premature ovarian failure. Let me show you quickly also the mutations, the protein complex MCM8 and MCM9. These protein complexes are also associated with chromosomal instability. I'll show you in this slide. Those, the MC8 and MC9, they interfere with the production, with the duplication of the chromosomes, and this crossing of the chromosomes affect the stability at this stage of meiosis, and it will end up at the end with oocyte apoptosis, death, and eventually cell death. And it ended up having follicular atresia. What complications come from premature ovarian failure? Infertility is the main one, the main concern even for the patient. Osteoporosis, depression and anxiety, heart disease problems, dementia, and Parkinson's disease. These are complications of premature ovarian failure. So how can we treat those patients? These are some of the expressions or some of the answers of patients when they were told that they have premature ovarian failure. So treatment of premature ovarian failure is focused on two things. Treatment with hormones, what's called hormone replacement therapy, and the second one is fertility treatment. With the fertility treatment, we go for fertility preservation. We take the ovarian cortex, we freeze the oocytes, we freeze the embryos, we freeze the donated embryos, not in our place, but I mean in general. Adoption is another choice for those patients who have poor function. The treatment is focused in cases of idiopathic and hereditary and autoimmunity on the following types. The hormone replacement therapy to maintain the well-being of the patient, psychological therapy and support, androgen-dependent therapy, corticosteroids therapy sometimes, dihydroepiandrosterone therapy, and puberty induction. The final one is the new one, is the stem cell dependent therapy. This is a quick look at the stem cell therapy. This is from the China group, and the China group have developed what's called mesenchymal stem cell treatment to rejuvenate the ovary. The rejuvenation of the ovaries are coming very soon. We can use the patient stem cell, ovarian stem cell to rejuvenate the ovary. In this mesenchymal stem cell, they are promoting the development of follicles, and they are inhibiting the apoptosis, improve the differentiation of the primordial germ cells, increase the formation of ovarian blood vessels and reducing the oxidative stress to the ovaries, and immune regulatory and anti-inflammatory effect and homing effect. I will not go to more details, but in fertility treatment, 75% of the normal 46XX spontaneous happening primary ovarian insufficiency have potential follicles remaining in their ovary. It is estimated between 1,000 to 10,000 follicles are still there, and that's what we are focusing on. The histological evidence that inappropriate follicle luteinization is the most common pathophysiological mechanism that prevents ovulation and pregnancy in those patients. 5 to 10% of those who are having premature ovarian failure become pregnant with no treatment even. Well, the other option is donation, egg donation, IVF, or adoption, and some choose not to have any children. The DHEA as a treatment, there was a study in 2010 saying that it is improved with the use of DHEA. In 2018, the study had followed patients 12 months and found that the first conclusion was not true. What we need is a long-term randomized studies to prove whether the DHEA is of value in premature ovarian failure. This is the main, the golden part of the talk, ovarian tissue cryopreservation. Actually, the first one to prove that they can help the premature ovarian failure was Kawamura in Japan with Stanford University. They took ovarian tissue outside, activated, implanted back, and had IVF for that patient, and of course ended up having normal, healthy babies. This is what's called in vitro activation of ovarian tissue. They have found as well that they don't need to take the ovarian tissue outside and reactivate it. It's just taking the ovarian tissue, mincing it, again in the same session, fixing it in the ovarian fossa, then they can stimulate the patient. This is what's called the HIPPO pathway, and this is interrupted in cases of premature ovarian failure. And we have found that what's called AKT will interfere and help shifting those follicles into an active follicles. This is what's called conventional in vitro activation. As I said, laparoscopy. We take ovarian tissue, we mince it outside, we can cryopreserve, or we can activate it and put it back. This is with a drug, and this is without a drug, just fragmenting it, autographed, and then we do IVF for them, and we have children out of that. This is a new study. This is by PLENARY, and they have proved that drug-free in vitro activation had helped some patients, and pregnancy had happened, clinical pregnancy, 3 out of 7 in those patients. This is how we do the cryopreservation of the ovarian tissue. We do it in our center for patients who are going for cancer therapy. This is the way we are doing it. We take the tissue, we make a pocket, then we do stimulation, and these are the follicles that contain the eggs, and we can help them. This is work of Oktay. Oktay had used the robotic surgery to re-implant the tissue again and then stimulate. He had in his group a live birth of almost 27%. This is the protocols, how we shift them from premature ovarian failure to the end having IVF treatment and eventually pregnancy. I will conclude with this study by Castren and Schumacher. This is the study about the premature ovarian failure and all the studies that have been done to help those patients achieving pregnancy. These are the etiologies they have looked at, and this is the outcome of all these 52 studies. At the end, they ended up having 59 pregnancies. There are different protocols which are used. These protocols have been used in IVF, and these are the different observational study, uncontrolled interventional trials, and of course, randomized trials and their outcome. So in conclusion, premature ovarian failure requests multidisciplinary management, address its complex physical and psychological consequences. Drug-free in vitro activation could be a useful therapeutic option for patients with premature ovarian insufficiency, leading to a successful IVF outcome. Many factors may influence this: a greater understanding of the approach of treatment help, and of course, absence of large-scale prospective randomized control trials affect the outcome. Thank you.